Talking about the basal ganglia, just like the cerebellum, we're going to skim over the anatomy part. I don't expect you to know all the details of the names of the parts of the basal ganglia. Just know that the basal ganglia is a group of um, nuclei that run throughout the brainstem and cerebrum, and they perform motor and non-motor functions. So we want to know the major roles of the basal ganglia, and generally we're talking about motor. There's some cool non-motor functions, but we're just going to kind of skim over them. But we're also going to talk about the signs and symptoms and pathology and etiology of Parkinson's and Huntington's disease. We're going to look at some different symptoms: akinesia, hypokinesia, rigidity, freezing, visual perceptual impairments, postural instability, resting tremor, and hyperkinesia that are associated with some of those pathologies. So the basal ganglia, its main function is to predict the effects of various actions and make and execute action plans. So pretty fancy, right? It includes several nuclei in the midbrain, and the term basal refers to the location of the nuclei in or near the base of the cerebral hemispheres. So it's very kind of curled in there around the thalamus and the subthalamic nucleus, and some of those areas are part of it. But it's wedged there in the most important part of the brain, and it has a lot of important function. So there are a lot of neurotransmitters that are created in the nuclei of the basal ganglia. The cortical motor areas produce excitation of the basal ganglia nuclei by delivering the transmitter glutamate. And remember, we said that was the major excitatory neurotransmitter in the central nervous system. Dopamine, which is made in the substantia nigra, pars compacta, which is right near the basal ganglia nuclei. Dopamine serves to adjust the signals to the output nuclei. So the output nuclei provide the appropriate level of inhibition to their target nuclei. So it's sort of like the basal ganglia is a control system. It controls unwanted movement. It prevents excessive lower motor neuron stimulation through its effect on the upper motor neurons. So it's really the upper motor neuron says muscles contract, 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 and the basal ganglia says, maybe not that much. So it's a like a control mechanism, and so it inhibits just enough, and it lets just enough of the signal get through. You want to think of it that way. So there are some non-motor circuits having to do with goal-directed behavior, social behavior, and emotion. And these circuits contribute to prediction of future events, selecting desired behaviors, preventing undesired behaviors, shifting attention, and spatial working memory, all very important stuff, right? So the example that they give in the text, I think they give this one in the text, but anyway, you're driving. Driving is a high executive function, goal-directed behavior sort of thing. Also, social behavior and emotional. There's everything's involved in driving. Just why I never drive, or rarely. But so you're coming up to an intersection. There are a lot of pedestrians. The light's about to turn. You're on your way to an appointment, so you got to get there on time. So you've got a lot of stuff going on. And the basal ganglia have a function in saying, like, okay, I think the light is about to turn red. Can I make it through the light? Look at all these pedestrians. Are they going to try to cross once the light turns red? How am I going to avoid running over them? So you want to predict the future events. You want to select the desired behaviors, and you want to prevent undesired behaviors like running over pedestrians. And shift attention to, like, oh gosh, there's someone crossing right now. And spatial working memory, like where is everything in space? So the basal ganglia are super important for just day-to-day activities as well as non-motor and motor. So, most of the basal ganglia, the motor circuit regulates muscle contraction, muscle force, multi-joint movements, and the sequence of movements. So it has an effect on movement, even though there's no direct output to motor neurons, just like the cerebellum. Interesting, right? So, the basal ganglia motor circuitry regulates contraction of postural and girdle muscles. It elicits rhythmic lower limb movement similar to walking or running. And they're also involved in decision making, judgment, prioritizing information, emotional processing, and emotional responses, learning, eye movement, spatial attention, and motor output. That's a ton of stuff. The basal ganglia are busy, 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 busy. So the main thing that we want to think about for motor function of the basal ganglia is that sequencing of movements and regulating muscle contraction and muscle force and multi-joint movements. So even though the basal ganglia have profound effect on movement, like we said, they have no direct output to motor neurons, lower or upper. They do talk to the upper motor neurons. They hang out in the same places in the cerebellum and in the cerebrum, excuse me. Functionally, the motor loop regulates activities in three pathways: voluntary muscle activity, postural and girdle muscle activity, and walking. So the basal ganglia are very important for regulating those three activities. Movement disorders in basal ganglia dysfunction range from hypokinetic, so too little movement, to hyperkinetic, excessive movement. So you got to have just the right amount. It's Goldilocks again. You can't have too little movement or too much movement. It has to be just right. So the differences in abnormal movements are due to dysfunctions in the motor pathways within the basal ganglia. Parkinson's disease is primarily hypokinetic. Huntington's disease is primarily hyperkinetic. So, whoa, my PowerPoint was out of whack there for a minute. So, Parkinson's disease is the most common basal ganglion motor disorder and it interferes with the voluntary and automatic movements. And even though it is classified as a motor disorder, there are lots of non-motor symptoms that go with it as well, because basal ganglia has a lot of non-motor functions. So Parkinson's interferes with both voluntary and automatic movements, and it consists of two common subtypes: postural instability, gait difficulty, PIGD, also probably more commonly known as akinetic or rigid type, or tremor dominant. So the prevalence of each of the subtypes is akinetic is about 50%, tremor dominant is about 40%, and mixed is about 10%. So little of each. So an akinetic subtype of Parkinson's, this is kind of what we imagine as typical Parkinson's disease. Typical idiopathic Parkinson's is characterized by muscular rigidity, drooping posture, rhythmic muscular tremors, and a mask-like facial expression. So sometimes people's hand tremor, they call it a pill rolling tremor, where their thumb and fingers roll together. People with akinetic or PIGD, PD have difficulty coming to standing from sitting. Their gait is characterized by, and this is in the later stages, obviously, gait is characterized by flexed posture, shuffling gait, and decreased or absent arm swing. And a lot of times, initially the symptoms come on one side more than the other. And then in later stages, both sides are affected. The motor signs of akinetic Parkinson's disease progress in predictable stages. So the distinctive signs of akinetic or PIGD, Parkinson's, are, you can think of them as tremor, rigidity, akinesia, and postural unsteadiness. Um, Along with those, freezing during movement, visual perceptual impairments, and a mask-like facial expression. There's a whole catalog of non-motor signs that go with Parkinson's as well. The When you think of visual perceptual impairments, it's like there is a motor sensory disconnect. So it's hard to put together the sensory information with the motor act, like we've been talking about for a while. So, pretty interesting. But you can think trap, tremor, rigidity, akinesia, postural unsteadiness. The non-motor symptoms occur because of all of the contributions that basal ganglia make to non-motor functions. Parkinson's dementia is not like Alzheimer's dementia. Usually they don't lose their memory, they don't have memory deficit, but they have visual perceptual issues and cognitive rigidity, cognitive slowness, bradyphrenia is what they call it. The incidence of Parkinson's disease dementia might be as high as 80% in akinetic Parkinson's. So pretty high incidence of dementia. And that usually occurs later in a later stage of Parkinson's. With tremor and freezing are really common with akinetic Parkinson's, and that is the one hyperkinetic sign that they have. Everything else kind of is hypokinetic. So it's a resting tremor. So with cerebellar dysfunction, you have an intention tremor where it happens when you're moving. With Parkinson's disease, it's a resting tremor. So people with akinetic Parkinson's often have episodes where their movement abruptly ceases, despite their intention to the contrary, known as freezing of gait or fog. It's often triggered by visual cues that don't normally affect movement, like going through a doorway or moving from one floor surface to another, or having to go through like a turnstile or something like that can sometimes trigger an episode of freezing of gait. And it's really, people hate it. It's really challenging to deal with, but you there are some techniques that we can use to help break people out of a freeze. Sometimes I'll call it the floor glue. It's like your feet are glued to the floor. Your body wants to go forward, but your feet don't. People with tremor dominant Parkinson's experience both resting and action tremors. Rigidity and slowing of movement are relatively mild. It's more of the tremor is the issue. They tend to experience a slower progression of signs and symptoms than those with akinetic Parkinson's. However, the progression of akinetic Parkinson's is incredibly slow. The differences between tremor dominant and akinetic are attributed to damage or degradation of different regions within the substantia nigra pars compacta, which is where the dopaminergic cells reside. So when different areas are damaged, it has different effects. Makes sense to me. The pathology in Parkinson's disease is the death of dopamine producing cells in the substantia nigra pars compacta and acetylcholine producing cells in the pedunculopontine nucleus. Cell death occurs long before the clinical signs of Parkinson's become evident. So by the time you actually have clinical signs that are recognizable as Parkinson's, you've probably lost 80% of your dopaminergic cells. So that's why Parkinson's is usually diagnosed later in life. There is a version called young onset Parkinson's, but for the most part, people get diagnosed when they're in their 60s, 70s, or 80s. So you're losing cells long before the clinical signs become evident. It's classic idiopathic Parkinson's is treated with medication. Drugs that replace dopamine are initially effective, like carbidopa, levodopa, or Sinemet is the main drug that is usually first tried. Side effects, especially with long-term use, can be hallucinations, delusions, psychosis, and dyskinesia, which is uncontrolled movements. And the progression of the disease with involvement of other cells and neurotransmitters limits the effectiveness of the medications. So sometimes people they can be on the medications for a long time until they get to the point where the side effects are too much for them, and then they go off, and that's challenging because it really does affect your movement. There are some invasive surgical procedures. There's a procedure called deep brain stimulation where they implant a stimulator in your brain. And people with deep brain stimulation get good motor effects early on, but they tend to have more speech and swallowing effects earlier than people who don't have deep brain stimulation. Um, there are some neuronal transplantation and destructive surgery that are done, which have variable effects in different people. There are also some stem cell treatments, which again have variable effects in different people. I know of one person who had stem cell treatments, and the first time he had it done, he had really good results and a lot of improvement in motor function, and then it slowly degraded over time. He had it done a second time, and he didn't have the same effects the second time. PT and OT are essential in improving mobility and functional status in people with PD. Intense training is important. You have to drive people with Parkinson's. When I was in school, and even the American College of Sports Medicine and other things, they used to say, don't work people with Parkinson's too hard, make a really easy program. And now all the research says, work them hard, drive those people. You want to produce muscle hypertrophy and functional gains. And intense resistance training is going to provide that more than standard exercise. So you have to train intensively with Parkinson's. Interesting. There are a whole bunch of, there's a classification of disease that's called Parkinsonism. It's not Parkinson's. It's atypical. It's a collective name for primary neurodegenerative diseases that have motor signs similar to Parkinson's, but the cause is different. So, primary neurodegenerative disease indicates that the cause is either idiopathic or genetic. Some of the syndromes included in atypical Parkinsonism include progressive supranuclear palsy, PSP, Lewy body dementia, and multiple system atrophy. Really, if somebody said, okay, you have to choose one of them, you have to choose classic idiopathic Parkinson's, PSP, Lewy body dementia, or multiple systems atrophy. I'm with classic Parkinson's all the way, because you can actually do something to slow neurodegeneration. With PSP and Lewy body dementia and MSA, you really can't, unfortunately. And I've worked with people with all of those things, and it's a very rewarding area to work in therapy, but the prognosis for the atypical Parkinsonism is much worse than the prognosis for classic idiopathic PD. So the symptoms they have similar signs and symptoms to classic Parkinson's from true idiopathic Parkinson's, but the red flags for a different diagnosis include early postural unsteadiness, and some people have what they call rocket sign, where they go to stand up and they lurch back, and it's like a rocket taking off. And lots of falls, rapid progression of signs, respiratory dysfunction, abnormal posture, emotional lability like uncontrollable and inappropriate laughter or crying, and signs of cerebellar, corticospinal, or voluntary gaze dysfunction. There's a gaze palsy with progressive supranuclear palsy that sometimes they'll call it doll's eyes. It's like those old-fashioned baby dolls where you laid them down and their eyes would close, and then you stand them back up and their eyes open. That gaze palsy is common with people with progressive supranuclear palsy, and they have difficulty looking up and like meeting people's eyes. That's often very difficult for the family of people with PSP because they're not going to look right at their friends and family. Um, Progressive supranuclear palsy is one of the ones with early onset of gait instability and tendency to fall backwards. That's that rocket sign where they go to stand up and they push back. Axial rigidity, which is common with a lot of Parkinson's, freezing of gait, depression, psychosis, rage attacks, and that gaze palsy that I just talked about. Lewy body dementia causes early generalized cognitive decline, visual hallucinations, and then the motor symptoms that are classified as Parkinsonism. Multiple systems atrophy is a progressive degenerative disease affecting lots of areas of the brain. So the primary disease, Parkinson's disease, um, is one thing, but then all the atypical Parkinson's and corticobasal degeneration was another one that I didn't have on that list. But they have motor symptoms similar to Parkinson's, but they have a um, different pathology in the brain. And then there's secondary Parkinsonism, which is traumatic, toxic, infectious, or drug induced. So secondary Parkinsonism is disorders with signs that mimic Parkinson's, but the cause is known to be toxic, infectious, or traumatic. It's often a side effect of drugs that treat psychosis or digestive problems. And it frequently leads to misdiagnosis and unnecessary treatment for Parkinson's disease in older adults. One of the things with atypical and secondary Parkinsonism is they do not respond to the medications that help people with classic idiopathic Parkinson's or typical idiopathic Parkinson's. Signs of drug-induced Parkinson's include subacute bilateral onset with rapid progression, early postural tremor, and involuntary movements of the face and mouth. So with typical idiopathic Parkinson's, it's slow onset, unilateral onset with a slow progression. And so those are kind of the distinguishing features. Chronic traumatic encephalopathy can cause secondary Parkinsonism, um, and it also involves disordered thinking, depression, memory loss, and dysfunction of goal-directed behavior and disinhibition. So usually there is, when they diagnose it, there's a history of multiple incidents of head trauma and accumulations of tau protein in the basal ganglia and other brain areas. It can be caused by physical abuse, like getting beat up, epilepsy, headbanging behavior, war injuries, or athletics. The athletic causes of chronic traumatic encephalopathy include American football, professional wrestling, soccer, hockey, boxing, anything where you have repeated head trauma can eventually cause that. So hyperkinetic disorders involve abnormal involuntary movements. Huntington's disease is an autosomal dominant hereditary disorder that causes degeneration in many areas of the brain, in the basal ganglia and cerebral cortex. And the signs of the disease include chorea, which is an uncontrollable writhing movement, and eventually dementia. Dementia is later. Dystonia is another hyperkinetic disorder where there's abnormal tone in muscles. Tourette's disorder and dyskinetic cerebral palsy are also hyperkinetic disorders. So dystonia is often a genetic disorder characterized by involuntary sustained muscle contractions, causing abnormal posture, twisting, and repetitive movements. It often increases during activity, emotional stress, and completely vanishes during sleep. And tremor is frequently associated with dystonia. Generalized dystonia is often progressive and affects the limbs, neck, and trunk. Tourette's causes vocal and motor tics and involves abrupt, repetitive, stereotyped movements. Many people with the disorder are aware of a nearly irresistible sensory urge that precedes the tic. Stress, emotional excitement, and fatigue can exacerbate it, and they can be temporarily and voluntarily suppressed, but the urge to tic builds during suppression. The onset is usually during childhood. So the thing that you hear about Tourette's is like people yell out words or something like that, but it can also be physical tics. It doesn't abrupt movements. Dyskinetic cerebral palsy is abnormal involuntary movement, um, often called choreoathetosis. It's like a writhing movement. Muscle tone and posture are abnormal, and there are CP lesions that involve the basal ganglia and part of the thalamus that happen before or around birth. And so it's non-progressive, but it's the movement disorder is characteristic of dyskinetic cerebral palsy. So the basal ganglia are a group of interconnected nuclei located in the cerebrum and midbrain. Basal ganglia pathology causes a spectrum of movement disorders, either hypo or hyperkinetic. They also regulate goal-directed behavior, social behavior, emotions, and oculomotor control.